I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. I just want to welcome Susan Dentzer, who's one of the most knowledgeable people I know about physicians and care delivery and different payment models in the United States. And she is the president and CEO of America's Physician Groups. So why don't we start, Susan, why don't you tell us about the focus of America's Physician Groups and why you're different from other physician organizations?
Absolutely, Peggy. And first of all, I want to say what a pleasure it is to be speaking with you, given your leadership in the field of quality and healthcare for so many years. It is a true honor. So thank you for your service to our nation and to all the patients of America, and of course, the providers of America who aspire to do well by them. So America's Physician Groups is an organization that represents large physician groups that are committed to value-based healthcare, by which we mean care that is accountable for both the costs and quality. So about 360 different groups are part and parcel of APG. They range from independent physician groups to medical groups affiliated with some major health systems and others. And all of them are either in alternative payment models, particularly the Medicare Shared Savings Program.
So what are some of the contributions that APG members have made to advancing value-based care?
Well, over many years, we have been in various arrangements, often taking on risk for providing care that we do believe have delivered superior outcomes relative to, say, outcomes achieved in the conventional fee-for-service payment system. Most recently, we've published just in the last couple of months 2 articles that have looked at the risk arrangements under which our groups operate in Medicare Advantage and what outcomes are achieved, first of all, relative to what happens when you are in non-risk-based models in Medicare Advantage. We published an article in JAMA Network Open in January that looked at that comparison. So comparing our medical groups that are in two-sided payment arrangements with Medicare Advantage plans, what results do they get for patients relative to groups that are paid for on a fee-for-service basis in Medicare Advantage. And what we were able to show then across a number of care domains was superior care. So whether you looked at hospital care, avoidance of care in the emergency department, avoidance of disease-specific admissions, especially for chronic illness, and then some measures of outpatient care, we achieved superior results versus what was seen when even our groups were paid on a fee-for-service basis by Medicare Advantage plans. We then have published an additional article just a couple of weeks ago in the American Journal of Managed Care that looked at the spillover effects that happens when our groups are taking care of Medicare Advantage patients in these two-sided risk relationships, but what happens when they are also caring for traditional Medicare patients. And those results were very similar. It showed that because our groups can adopt through Medicare Advantage infrastructure, various care delivery approaches, and a lot of other elements that enable them to really provide optimal care for patients, especially at the primary care level, that this enables them to deliver better results for all patients. And even as they're achieving these superior results for Medicare Advantage patients, those spill over to their traditional Medicare patients as well. So the traditional Medicare patients end up seeing similar reductions in hospitalization overall, use of the emergency department, disease specific admissions, disease specific readmissions, even. All of that spills over to them. So we think those are pretty airtight demonstrations that we truly can achieve better results through these different payment arrangements and what they enable us to do by way of care delivery innovation.
So you mentioned the term two-sided risk. I wonder if you could just tell us what that actually means. And maybe start out by just talking about fee-for-service and the incentives that fee-for-service offers.
First, I will acknowledge that most health economists will tell you there's no entirely benign set of financial incentives, right? All financial incentives have consequences. But then there's a question of what's better and what's worse. So the old saw is what happens if you have a system that pays surgeons for amputations? You get a lot of chopped off legs because the financial incentive is on the surgeon to amputate. This remains true today in the United States. A surgeon who performs an amputation of a limb of a diabetes patient is paid much, much more than the person who is basically working hard to help the patient with prediabetes avoid moving to full-blown diabetes, let alone down the road to serious complications such as amputation. So fee-for-service is paying physicians largely on the basis of volume. It's only been relatively recently in our history that we started to tie more quality measures to fee-for-service based payment, particularly in Medicare. So you contrast that with two-sided risk, which means in the case of our groups, they are paid by health plans who may delegate over a certain corpus of money to them, basically capitation, and you're given dollars on a per person basis to care for the patient for the full year. And you are accountable for the costs of that. You have to deliver care within that payment envelope, the cost of care. And you are also held accountable for quality metrics. Those are built in. So any of these payment contracts that are struck between payers and our groups have both spelled out what are the cost thresholds that need to be achieved and what are the quality thresholds that need to be achieved. If you undershoot the cost threshold and you overshoot the quality threshold, you win. You actually get paid more in these contracts. If you don't meet those thresholds, if your spending goes up over and above what you've been committed to be paid, or your quality falls short, you lose, you pay. You earn less out of the contract, and you may be subject to penalties. So that's two-sided risk in a nutshell.
So what have been the primary roadblocks to expanding this thing that we call value-based care nationally?
One is, for the most part, we have kept most of this activity voluntary. There have been very few mandatory requirements that any providers or any payers, for that matter, move into these arrangements. And when you think about the incentives on the fee-for-service side, which are really pretty extraordinary, why would anybody do this? It's much, much, much harder to put together a risk-based contract. And there's more risk for providers and there's more risk for payers in that. And frankly, until the incentives to stay in fee-for-service are worse than the incentives and the benefits for going to these alternative contracts, there won't be enough of this activity. So that's, I think, far and away the biggest obstacle. Other obstacles, I would say, is it takes some real sophistication to be able to manage risk. You've got to be able to assess what your risks are. You've got to be able to have the financial acumen to manage those risks. You can't just provide all the care you want and expect to be paid. You have to make decisions internally about where you're going to get the biggest bang for the buck to take care of patients. For example, If you're going to be in Medicare Advantage, you need to understand risk adjustment and how you code appropriately for conditions so that you get the risk adjusted payments that will help you provide the care that you need to provide. You need very sophisticated electronic health record systems. You need to be able to have the capacity to put together patient registries. You go out proactively. You get patients to come in and see you once a month, or you get a nurse coordinator to call them and ask them how they're doing, or you have remote monitoring equipment installed in their homes. All of those very proactive activities cost money, and you need the capabilities also to understand when and how to use them. And that is not a factor that is as widespread throughout the healthcare system as we need it to be. So, just a few examples of the kinds of things that are necessary to provide two sided risk care and value based care.
Let's talk about, I think, the big success story of this model in terms of actual uptake by consumers or patients is Medicare Advantage. And what is the percentage of Medicare enrollees that are now in Medicare Advantage, Susan?
If you look at those Medicare enrollees who are in both parts A and B, because you have to be in those two parts of the program to be in Medicare Advantage, it's about 56%. Many people don't want to be locked into a provider network. And frankly, traditional Medicare is one of the few aspects of health insurance left in the world that has a pretty open network. You can go to any provider who so-called accepts assignment in Medicare, and that's 95% plus of clinicians who cater to the older adult population do accept Medicare assignment.
Medicare Advantage really is the big success story, I think, for value-based care. So why isn't the success of Medicare Advantage better known? We read a lot, especially in newspapers and whatever journals, about the downsides, but I don't think we read a lot about the upsides. And I know you've done a good job of pointing some of them out, but why is this happening? Why aren't we getting a clear look here?
It is not a perfect program. It's been well documented that on a per person basis, a per beneficiary basis, Medicare Advantage does cost somewhere between 10% and at the high end, the estimates are 22% more per beneficiary to run the program. Now, some people look at that and say, well, that means it's bad just by definition, and therefore we need to lower the cost of it down to traditional Medicare. We look at that and say, no, look what else is going on in this program. First of all, patients are getting more benefits. Almost all Medicare Advantage plans will offer some dental, hearing, and vision coverage. And on top of that, we think Medicare Advantage done right does equip practices, especially on the primary care side, with a lot more resources to do a much better job coordinating care for patients, making sure that they get patient-centered care, et cetera. So we think that that payment differential, if you held it up to the light, you'd say people are getting more benefits and they are getting better care. So why should we not pay more per beneficiary for that? So why can't we get this story out? Again, I think there's a lack of understanding. Let's just take risk adjustment. The point is to give resources to practices so they can manage the care of somebody who's got diabetes, or so they could hire a behavioral health specialist to be on the payroll and help care for people, or so they can have somebody who's in charge of making sure that these patients have food to eat in their homes and other things. All the kinds of things that regular old fee for service won't pay for. You can use the risk adjustment system to get the resources to supply those things. And because there's a complete lack of understanding that this is part of the function of risk adjustment, I think that's part of the reason you've got so many people taking a quick look at the program, looking at this differential in payment per beneficiary, looking at risk adjustment and saying it's a hoax and saying that the whole program is bad. A lot of people are scared off by even the language around an HMO. There isn't a Medicare Advantage plan nowadays that doesn't start by finding you a dedicated primary care clinician. And in this environment in particular, where if you're in an urban area, I hear repeatedly about people who move to, say, the greater Washington, D.C. area and can only find a handful of primary care clinicians who will take them as a new patient and who essentially get told that they have to wait 6 months or more for their first appointment. And that's increasingly true in many areas. So if you have the choice of a system that is determined to find you a primary care clinician, because the whole basis of the care model is predicated on you having access to good, consistent primary care, why would you not be drawn to that model as opposed to something that says, in effect, you're on traditional Medicare? Good luck finding a doctor now. So I think for patients to understand how the model works, obviously Medicare Advantage plans can do even more to educate them. I guess the question is, where do we go from here, right?
Yeah.
If you look on the plus side of the last 15 or 20 years, we've got more patients than ever before covered with health insurance. And insurance doesn't guarantee you access to good health care, but it's a necessary and not sufficient prerequisite for getting access to good health care. So start there and then take these relationships that are now possible for us to have between payers and providers, move more of them into these kind of risk-based models with provider groups taking on the full accountability for the total cost of care. Providers should not be held harmless in this. If you don't have providers fully accountable for the cost and quality of care, we're not going to continue to make the progress in the system that we would like to see. And then to the degree that we're dealing with the Medicare population, I think continuing to make sure that the Medicare Advantage program works as well as possible, and it does need changes. We would be the first to say that. We need to continue to improve risk adjustment methodologies. We can examine other features of the program that probably aren't necessary. There are some supplemental benefits that Medicare Advantage plans offer that maybe aren't really driving improvements in health status, and we could get rid of those. So there are positive things that we could do there. And then if we care about traditional Medicare still and want to keep that part of the program for people who want to be in a more open-ended product, I think we still can do a lot to move toward accountability there. We have the Medicare Shared Savings Program that has been at least modestly successful in saving some money in the Medicare system. It could do more. And so we could do a number of things to expand ACOs in traditional Medicare. And frankly, if we did it the right way, you could start to put some more of the benefits that are available in Medicare Advantage into traditional Medicare as providers took on greater accountability for the costs and quality in that part of the system. And then that leaves another big area where we need to make progress as a country, which is the private pay part of the system, particularly employer provided coverage. And employers, I think, by general agreement, have been kind of behind the curve in demanding value-based approaches for the employees they cover. And there are a lot of complicated reasons behind that. But if we could get employer purchasers on board to continue to drive the system to greater accountability, demanding more action by plans to move in that direction, by payers and provider groups, then I think we could start to make some real progress.
I want to thank you very much for your eloquence and for your deep understanding of American healthcare and some of the issues that keep us stuck in this place. And you're kind of pointing at things we ought to do to make it work better in the future without bankrupting the country and the people. So thank you so much, and we'll see you soon.
And thank you, Peggy, again for your phenomenal work all of these years to make the system work better for all of us.
As I reflect on my conversation with Susan Dentzer around the evolution and impact of Medicare Advantage, it's important to place this moment in context. Just recently, CMS announced the 2026 payment rates for Medicare Advantage plans, including a 5.1% benchmark increase. When you factor in plans, coding practices, and risk scoring, that's expected to translate to a 7.2% revenue bump, the largest rate increase in a decade. It's a clear signal that Medicare Advantage is not just surviving, it's thriving. And yet, for all its success, the program has many flaws, including that very risk adjustment system that has been so controversial over the past couple of years. The early rollout of Medicare Advantage left many skeptical, and incentives are often not aligned, and quality isn't always guaranteed. So there's still plenty of work to do for Medicare Advantage. When it was introduced, it followed a number of scandals related to Medicare HMOs. And so the program was trying to make sure that people were not buying an inferior product when they chose Medicare Advantage. And that's how NCQA came to enjoy the position it enjoys in developing quality measures for Medicare Advantage. By building these rigorous measures and standards for Medicare Advantage plans, we are trying to ensure that the program supports all beneficiaries. Our work alongside the development of the risk adjustment system has helped correct the course of the program and ensure that plans would responsibly care for older and sicker populations and be resourced to do so. It isn't perfect and it still needs work, but the idea remains very powerful. You don't want plans to be cherry picking younger, healthier people. That's a very important point. Risk adjustment does make the model work in a number of ways. It ensures that resources follow the needs of the patient so plans and providers can serve the whole person. But risk, as we know, isn't easy to measure and isn't easy to manage. For payers and providers, it's still a challenging proposition. But I think the more important point is compared to what? So until the incentives in the fee-for-service Medicare program are less attractive than those in value-based care, we won't see the scale we need for a full system lift. So when Medicare is trying to compare Medicare Advantage to ACOs and classic Medicare to see what kind of quality are we getting and what kind of costs are we getting, they're hampered by the fact the measures do not align. And so we think that there is a very important job to be done to figure out some things that we can measure across the programs and to see that ACO measures are aligned with Medicare Advantage measures, since both of those are actually reflecting systems. This has been complex and difficult, but it remains seriously urgent problem to be solved if we are really going to drive a value agenda. Thank you again to Susan for this thoughtful conversation. Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.